Hi, everyone. Welcome to the podcast, audio and video of the Cleft Palate Craniofacial Journal. I'm Pat Chibbaro here in New York, pediatric nurse practitioner, and always love talking about papers that are not in my specialty because I think we all need to know a little bit about what everyone else does on the team. And wanted to highlight a paper by one of my favorite groups, the Speech Language Pathology group, and this paper, which was posted online first on November 28th, is predicting communication-related quality of life in children with velopharyngeal dysfunction. And the authors are Robert Fujiki, John Monday, Manasa Kaluri, and Susan Thibault. And they are from the Department of Otolaryngology, Head and Neck Surgery, Indiana University, the Department of Communication Sciences and Disorders, University of Wisconsin-Madison, School of Medicine and Public Health, University of Wisconsin-Madison, and the Department of Otolaryngology from the University of Wisconsin-Madison. And I love when I see people who have worked together on important research. So thank you so much, Robert, for joining me for this.
No, thanks so much for having me.
So let's talk about this paper in a way that I and others who are not speech pathologists can understand, because a lot of, as I read this and I feel like, oh, this time when I read this, I am going to totally understand all of the speech language pathology jargon, because I have really been trying and I still can't quite get it. So I would love if you could just, before we even talk about the paper, just what motivated you to actually do this work. And I understand that this is work that you were doing when you were actually in Wisconsin.
Yeah, I did this while I was with the team in Wisconsin. But yeah, I think this was kind of motivated because, as you know, and as everyone, throughout a craniofacial team knows, craniofacial anomalies are just so complex that I think it's easy with all the treatments and providers to kind of lose track of patient experience and what it must be like to be a child or a caregiver of a child with a craniofacial condition. And so we were really interested in examining quality of life, which is kind of, in my mind, kind of where the rubber meets the road, and
Yep.
looking at what factors really contribute to quality of life.
So maybe if you can give us a little bit of a walk through your work, and then we can sort of pull out some pieces of it that we could talk about.
Yeah, I'd love to. So in this paper, we were looking at communication-related quality of life, which I define as the kind of the extent to which an individual's speech supports meaningful communication and just kind of participation in daily life. And so we were interested in examining factors that derive communication-related quality of life. And we measured this construct using a tool called the VPI Effects on Life Outcomes instrument, which is much more commonly known as the VELO. And this,
Hello.
yeah, the VELO, and is used in quite a few craniofacial clinics, I kind of think throughout the country. But it's just a patient-reported outcome measure that can be completed by a child if they're over the year 8 years old, and by a parent if the child is younger than that. And it gives you a total score and then also looks into some subscores of different aspects of communication-related quality of life. And so then we looked at a lot of different factors and tried to identify predictors of these VELO scores. So we looked at things like speech characteristics, medical comorbidities, surgical history, behavioral health profile, socioeconomic status, as many factors as we could find to see kind of what drove this outcome. And what we found was that hypernasality, or just nasal air leak during speech, as well as overall intelligibility, which is just kind of overall how easy is the child to understand. Those two factors were the biggest drivers of this outcome measure overall. And then we found a couple different things that impacted certain sections of the VELO. The presence of a behavioral health comorbidity, again, made it so just overall scores were a little bit lower. And then we also found that the presence of glottal stop articulations or substitutions, and that's when you might get say if you were saying baby bib and instead you might have if. So you're getting kind of that a stop on the level of the vocal folds that's replacing a sound or said with the sound. But we found that the presence of that particular articulatory pattern was associated with worse emotional impact scores, indicating that it may attract negative attention or have emotional consequences for children.
Yeah, I know that you were talking about, there was some part of your paper talking about the anxiety that a lot of kids have in terms of when they speak, will they be understood?
Yeah,
And go ahead.
I feel like that's really, at the end of the day, all of the things we do with speech kind of lead to, can you get your point across? And there is a lot of anxiety with kind of not knowing how successful you'll be in a different, social context with that. So I think that's really, high up on patient and caregiver priorities, is just that overall intelligibility. How clear can you be with your point?
So then what did you find that you expected, and what did were there anything that anything that you found that was surprising to you?
Yeah, I think we were kind of expecting that overall speech intelligibility might kind of be tied with communication related quality of life, just because it kind of makes sense. And then we were also not too surprised to see that the hypernasality was something that was tied into communication related quality of life, particularly in this population, since that's something we spend a lot of time thinking about and trying to address as a team. I think something that surprised me more was how dramatic the pattern with the glottal stop substitutions was, because for the most part, we didn't see any patterns with specific articulatory um, patterns, or sounds, but it was more just kind of global measures. But then it was really interesting that this sound in particular really seemed to attract more negative response emotionally. And I think it's potentially because it is a sound that, at least in American English, is not common. So I think maybe listeners aren't as used to hearing it. And so it maybe attracts a little negative attention that way. And it
Mhm,
also tends to doesn't sound a lot, oftentimes, like the sounds that it replaces. So it oftentimes, I
mhm.
think, affects that overall intelligibility again.
So then, one of the things, and I think I was telling you before we started that I was just podcasting another speech paper with a couple of your colleagues,
Yeah.
and just was thinking about the training that SLPs have. And one of the things that I had learned over the years from working with a couple of speech pathologists was, and correct me if I'm wrong, but that in order to train to become a speech pathologist, you don't have to take an actual course on speech therapy for kids with clefts. And I'm wondering, do you think that what effect does that have when you, as a speech pathologist on the team, if you are having to refer patients out for speech therapy, how do you then know whether or not that speech pathologist in a local community setting, or in that patient setting, has the really has the expertise to be able to help kids with with the kind of problem that you identified specifically? We're talking about the glottal stops.
Yeah, that's a great question. And you're totally right that level of speech language pathologist training regarding kind of cleft specific speech patterns is really variable. And I think in a lot of settings too, you don't necessarily see these types of patients that often. So it can be difficult to kind of develop that expertise on the job. Yeah, so there are specific errors that tend to be, or patterns that tend to be maybe more associated with this population, and those glottal stops being one. Another one's being kind of like nasal fricatives, where a child might send a bunch of air like through the nose trying to make a sound, or pharyngeal fricatives, where they might try to create an area of constrictions. It's like, or kind of back in the pharynx somewhere. um, and so I think oftentimes what I'll think about a little bit is, if it's a sound that's really unusual in other populations, we might try
Hmm.
to see if we can do a couple of sessions to get a child started with someone on the cleft team who has a little more experience with those particular sounds.
Hmm.
Um, Other times we can also, in our notes, like include some suggestions or ways to kind of target those sounds initially. We also try to, as much as we can, be in contact with the school SLPs, because oftentimes they're totally capable of addressing these different sounds, but they may have a little less confidence about what is anatomical versus a functional pattern. And so we can talk through that a little bit. So I think we try to really be as collaborative as possible just to make sure that, the child can get as many services specifically targeted to what they need, as they can.
So there were a lot of interesting things that I read in some of your discussion. One was it was concerning that children facing economic deprivation scored more poorly on the swallow section of the VELO. Can you talk a little bit more about that? It's really interesting that you're able to sort of pull some of those things out, from your assessment of these kids.
Yeah, and that was another finding that would go kind of in that unexpected
Yeah.
category. Yeah, so the swallowing section of the VELO, it's almost a little bit of a misnomer because all the questions actually look at oral nasal regurgitation.
Mhm,
So this would suggest that children coming from less advantaged homes were experiencing more of that symptom where food or liquid comes out the nose.
mhm,
Um, and it's a little tricky to know exactly why, but there has been some really interesting work that came out just recently looking to see that social determinants of health oftentimes predict both fistula rates and fistula management. So I have to wonder if it's related to that
mhm.
there may be more, or fistulas handled a little differently, or more delays to getting them repaired in that population, and that might be where we're seeing a little more of that symptom with where liquids and food are able to get up in and out the nose. But yeah, it was an interesting finding that we didn't necessarily expect to see.
Yeah, and the other, let's see, there was one of the other things that I wanted to mention. Oh, it's noteworthy that surgical technique was not significantly associated with VLO outcomes. Maybe talk about that a little bit.
Yeah, so we didn't see any effect of which surgical technique was used, which, that may just speak to the really talented surgeons that we had in Madison, because they really are great and they do a great job. But yeah, we saw that, like, just regardless of technique, that results were similar and pretty good. It also could be there's recent work coming out from the Cornet study, which has been a multi-institutional study going on that shows that oftentimes it's not so much the technique used as clinicians or surgeons skill with the technique, and surgeons tend to choose the techniques that they're really skilled at. So it could
Yep.
be, it's not so much the technique that matters as how good the surgeons are, and our surgeons luckily are really great at Madison. So
And you had so many things in your paper that I wanted to sort of pick through and ask you about. So let's see, that it was interesting that speech intelligibility rather than articulation testing significantly predicted VLO scores. Any thoughts about that, or want to talk about
yeah,
that a little bit more?
I think it's interesting that, like, at the end of the day, it didn't necessarily matter if every sound was said the way we would expect to hear it, like in the adult version of standard American English. What
Mhm.
mattered was how well the child could be understood. And I think that makes sense in that, your average listener isn't necessarily assessing every sound you say, but they are listening to hear if they can kind of get the overall message. So yeah, like with the exception of those glottal stops where something may kind of have
Yeah.
distracted from the overall message, I think it was more the overall speech intelligibility, which I think does have potential implications for treatment. Like, obviously we do need to assess and we do need to target like phonemes and
Mhm.
specific sounds. But I think there's also potentially sometimes a place to target strategies that improve overall ability to be understood, such as pace and vocal volume and other strategies like that.
Do you think that I'm thinking about some of my experience with kids at school who are in school and maybe facing some issues relative to their speech intelligibility, their acceptability, and one of the things I was thinking was how some of my patients I found they would sometimes tell me that I don't want, I'm having some, kids are making fun of my speech at school, but I don't want to let my parents know because I don't want them to be upset. And, and so that's what makes me wonder, are we really, are we really seeing what's actually happening to them in school? I know this is just a thought that I had that as I read papers like this. What are your thoughts about that?
No, I mean, I think it's so important. Yeah. And I feel that that's one way that patient reported outcome measures are really useful, because I find that I can interview a child and with the parent present, because they generally are. And I can interview a child and I can get a lot of answers that say like, oh no, my speech doesn't bother me. And then I'll go look at my patient reported outcome measure, either the cleft Q or the VLO or whichever one you use, and I'll find that like some of these answers don't line up with kind of the overall message the child gave me. And then and sometimes it's because the child may not have connected the dots that like, oh, I hate repeating myself. But I didn't realize that was connected to my speech clarity, or
Right.
sometimes it's that, like you say, the child didn't want to bring that up, but when you asked about it specifically on the form, it kind of came out. But yeah, so I think to me, like, I think it's so important to try to, hear the child's voice, like you said. And I find that having both kind of my interviewing in the clinic kind of supplemented with the patient reported outcome measure can be really helpful for getting a little bit more comprehensive picture of what might be happening.
Definitely. So what about the future? Are you working on anything else related to this, or what else are you working on? What can we see from you in the future?
Yeah, yeah. Our team is doing a related study, or kind of a follow-up study, that is looking at two different patient-reported outcome measures. So we had children do both the VELO and then another measure called the cleft Q, which has some speech modules. And we're comparing how the speech modules of the cleft Q compared to the VELO outcome, and we're seeing kind of how those differ or how they're related. And then we're also looking at factors which influence the cleft Q to see if they're similar to the ones that we see that influence the VELO. So we're hoping to kind of inform how clinicians might decide which one they want to use, and with which patients one might, be optimal, or how they decide which one they think is best.
All right. So we'll look forward to seeing that. So before I reintroduce the paper, is there anything else that you wanted to share about this work that you'd want the listeners to know?
Yeah, I mean, I think just overall, like, I think there's a lot of great work, happening in the field in general, looking at patient reported quality of life, and particularly communication reported quality of life. And I think something this paper highlighted to me is just how multidisciplinary, like, our field really is, and how multidisciplinary communication related quality of life is. That it's definitely not just a speech thing. It's our surgeon
Right.
and psychology and nursing and audiology, and all these different specialties really play a part in this. So I think it's a cool area of the field where we really work together.
Yeah, and that's one of the reasons I like to highlight papers from all different specialties so that everyone is exposed and trying to understand a little bit more what everybody else is doing. And really, it is caring for these kids is a total team sport. And so the more that I think I've learned about the speech aspect and what I can observe about the kids, and is really, really important. So thank you for this paper. Let me reintroduce it. It's predicting communication related quality of life in children with velopharyngeal dysfunction. Robert Fujiki, John Munday, Manasa Kaluri, and Susan Thibault from IU. Big Ten winners, by the way, from a
Who-
Michigan fan. I had to throw that in.
Yeah.
Sorry for my Ohio State friends. And they are from Indiana University and University of Wisconsin-Madison. Great paper, and it is posted online first, November 28th, so it shouldn't be hard to find because it's pretty far up there. And Robert, thank you so much for all your work and what you do for kids, and really appreciate your taking the time to be with me today.
Oh, thank you so much for having me. The pleasure is all mine.
Okay, great. Take care, everyone, and happy holidays. Bye now.